For many women, breast cancer treatment doesn't end simply when active treatment is over. Suddenly, you're dealing with hot flashes, brain fog, sleep disruption, intimacy issues, and a body that just doesn't feel familiar anymore. Yet there are so many of us who are never fully prepared for what menopause after breast cancer really looks like. In today's conversation, I'm joined by Dr. Corinne Menn, OBGYN, breast cancer survivor, and menopause specialist to talk about the physical and emotional realities of menopause after breast cancer and everything that we need to know to better advocate for ourselves and our quality of life. Dr. Menn, it is such a pleasure to have you here on Dear Cancer, I'm Beautiful. I am so excited to have you here. I can't even explain it.
Oh, well, thank you. This is such a joy to talk about things I'm most passionate about.
I've been following your work on social media for quite some time, and I was so happy to finally meet you at the Young Survival Coalition conference and also at the screening of the M Factor here in New Jersey. It's great to see you in action, and to have someone like you in our corner is just invaluable.
Thank you. Thank you. It's my silver linings playbook, which we'll get into.
One of the reasons I was so excited to have you on this podcast is because you bring something so incredibly unique to this topic. You're not only an OBGYN and menopause specialist, but you're also a breast cancer survivor who has personally experienced many of the challenges that we're going to talk about today. So I'd love to start with your story. You were diagnosed with breast cancer at 28 while training to become an OBGYN. Looking back, how did that experience ultimately shape the physician and advocate that you've become today?
Well, nothing is a better medical education than actually experiencing, frankly, what your patients have experienced. And, many doctors will obviously intersect with the medical, space in some way as a patient themselves. But for me as an OBGYN, really my breast cancer diagnosis and then also experiencing premature and then surgical menopause really kind of put me right in the crosshairs of really some of the biggest problems, I think, in women's health. And that experience shaped me because I realized that I was not prepared to take care of the average woman facing hormonal issues with natural menopause, perimenopause. I certainly didn't know how to take care of myself, which was the most complicated of those patients. So that experience and how I, frankly, looking back, was let down by the medical community, even though I'm very grateful for the care my medical oncologist gave me and my surgeons, and everybody was wonderful to the capacity that they were frankly trained in. But I just saw a glaring lack of care for a large scope of the collateral damages that I experienced as a breast cancer survivor. And it just changed the course of my life and my professional endeavors and now my mission.
And I would
Yeah.
imagine that it's so disappointing, not just to be a patient, but to also, be a healthcare provider who sees such a gap. What do you remember most about suddenly being thrust into menopause at an age when most women weren't even thinking about it? And like, when did you see this gap? Like, when was that moment like, wait a second, there's not enough information here?
So, honestly, when I look back, so remember, I was a second year OBGYN resident. So like, a lot, but there's a lot you don't know yet, right? I was still very young in my training. It was only the first half of my second year. And to take a quick little step back, my mom had been diagnosed and died of ovarian cancer just a few months prior to me getting my diagnosis. Now, we had no family history of ovarian or breast cancer. This was 2001. There was not a lot of, information about the BRCA1 or 2 gene, which we can get into. And there certainly wasn't a ton of emphasis on menopause care like there is right now. So when I was first diagnosed and then experiencing my initial temporary menopause, frankly, my biggest concern was fertility, right? All
Right,
I
because
could
you were
think
so
about,
young.
yeah. So really my concerns were not the long-term implications of an early menopause, premature menopause. It was, will I be able to become a mom? Like literally I was obsessed with it looking back, right? And, and so I think that lens that I came with, along with kind of the lens of my clinicians, they were really hyper focused on the impact on my ovaries really only because of the fertility concerns. And so they did address that. I did have, some fertility preservation prior to going through chemo, et cetera. But when I presented with what I now know are the classic signs of menopause, I was left with a prescription for Ambien, and that's it. I had
Whoa.
no help. There was no monitoring of my bone health, no really discussion about what it meant for my heart health or why I had new onset of anxiety and depression. And, and even the hot flashes and the night sweats, other symptoms were really kind of minimized, being like, yeah, you might have some hot flashes and some vaginal dryness, right? And so I kind of just rolled with it, frankly.
Like
And
many of us do, right?
yeah,
Because
yeah. And I
when
mean,
there's a life and death situation, and then these other symptoms, they get set
yes.
aside.
But when I look back, in fact, it really impacted my treatment because I actually declined my last two chemotherapy cycles because I was literally at that point so broken. I hadn't slept. I think my mental health was really poor. I had horrible joint pain. I was so fatigued. I had brain fog. I was trying to function as an OBGYN. I had to take a short leave of absence from my residency just to like kind of repair things. And I was newly married. Of course, there was significant impacts on sexual health. I was having recurrent urinary tract infections. I mean, the list goes on and on. Not one of those things were addressed at all by myself as a doctor myself. I didn't really know how to, I wrote a lot of it up to this is just chemo. But now I
Mm.
realize looking back at the timeline, for a younger woman, you don't necessarily go through abrupt menopause as soon as you get that first chemo dose. It could be, take a little bit of time. And so looking back, I was like I had finished AC and then I was moving into Taxotere. And it was after, I think starting that first, dose of Taxotere, finishing up the adriamycin and Cytoxan, that I think my ovarian function just really shut down. And then there was some new data out that giving injections for Lupron during chemo might protect your ovaries. So my medical oncologist is like, hey, Corinne, there's some new studies, because again, this was a while ago and this is more standard of care now. Why don't we give you some Lupron? I was like, oh, okay, anything to protect my ovaries because I wanted to be a mom one day. And I literally was like clueless that like in the next month, on top of the chemo and the Lupron, I was going to just be in this very abrupt, severe estrogen deprivation state. And I just was just so unprepared. And so looking back, I was uneducated. My clinicians were uneducated in how to help me or even ask about it. And it wasn't until years later that it all kind of came full circle. And I'll say I think what really hit the nail on the head was when I experienced premature menopause twice temporarily, and then from medications, et cetera. And then when I decided to have my ovaries removed after I had my first baby after breast cancer, that surgical menopause, I think that was really just made me just hit a wall and be like, okay, Corinne, you've been dealing with this for a long time. So you need to figure out how you're going to like live for the rest of your life, because now you're in your very early 30s with no ovaries, right? And that's when I started to do professional medical education and get involved in the Menopause Society. And it's been a really long process. I mean, it's been over 15 years really that I've been in that space. And it's been a long time learning of what works, what doesn't, how we can specialize our options for cancer patients and what cancer patients can consider hormones. What patients do we need to think of alternative ways?
I mean, I think perimenopause and menopause is complicated to begin with, and then you
Yes.
layer breast cancer into it, and now you're navigating. It's like, which door do I go? If you're dealing with a menopause symptom, how is that going to affect treatment? And it's very, very scary and confusing. What would you say was the toughest symptom for you personally?
I mean, literally not sleeping for a decade. I mean, full stop. The sleep, because looking back now, I realized the sleep, because it was totally out of control, because my hot flashes and night sweats were not well controlled, even though I was on Effexor, it helped a little bit. But I think the lack of sleep added to mood changes, fatigue, brain fog, anxiety. I think it impacted my relationship with my husband. I'm like, I didn't want to have sex. I wanted to like go to sleep at night, and then I couldn't fall asleep. So I think that was the biggest thing, and I just got fed up with that lack. And I think I can't live like this anymore. I need to have, and then It took me a long time to realize that it was that lack of sleep also that contributes to the weight gain and your body not feeling it. Because we know, even in women without menopause and, women without cancer, even, when you don't sleep well, it affects every aspect of your body and your immune system and everything. And so to me, I just couldn't take that aspect anymore. And that's often the very first place I start with patients. And then I would say the easy thing that I quickly learned I really needed better care for was to treat the genitourinary syndrome of menopause, which was impacting my life in more ways than just some dryness.
I can relate to the sleep. I mean, I had insomnia before I even had breast cancer.
Mm-hmm.
So once I had my ovaries removed prophylactically, before I even had breast cancer because of the BRCA gene, the sleep was not great. And then with treatment and everything. And, one thing I wanted to bring up was chemo brain. My therapist actually said to me, Melissa, I don't know if you have chemo brain or if it's the sleep deprivation. Like, where does the chemo brain come from when it comes to the menopause symptoms, and how can we differentiate it from sleep issues?
First of all, I can't stand the term chemo brain. Okay. Because here's the thing. I don't mean that chemo brain doesn't exist. I think there's data and there's understanding that when you're in the middle of chemotherapy and certainly, in the immediate aftermath, right? There are effects from chemotherapy on your brain. No doubt, no doubt. But let's call the persistent cognitive changes what it is for the vast majority. And let's talk about breast cancer patients in particular, right? Please don't call it chemo brain when you're 3 years since your last chemo infusion. I think we would do women a disservice when we tell them that. We're like, oh, it's just chemo brain, meaning like it's either, like this is just, the side effect from chemotherapy. I'm like, no, call it what it is. It's estrogen deprivation. You have menopause. When we're talking about, in particular, young women whose chemotherapy itself may have put them into, an early premature menopause. And in addition, a large percentage of these women are on some form of estrogen blockers or ovarian function suppression. And then there's another subset of us with BRCA or, other reasons who have lost our ovaries. And then when we have surgical menopause, we know clearly that menopause, that happens particularly abruptly and prematurely and surgically causes significant cognitive changes, as well as, again, nothing lives in isolation when you have significant sleep deprivation, uncontrolled vasomotor symptoms like hot flashes and night sweats. All of these things contribute to this quote unquote chemo brain. And so the reason why I don't like that women walk around being told it's like chemo brain is that it doesn't help you understand and identify what the real problem is so that you could work on real solutions, right? And it doesn't mean that every solution is that, the woman should have systemic estrogen given back. Although I do think we have got to move beyond this blanket denial that we can ever talk about that. There are a subset of breast cancer patients who could maybe consider it or other hormones, but we at least have to manage it even in a non-hormonal way with lifestyle and other things so that they can actually improve it, because you can't walk around for the rest of your life thinking you have chemo brain.
I can't tell you, Dr. Menn, how many times I've Googled chemo brain and tried to find experts that could speak to it. But now what you're actually bringing to the surface here is that it's most likely it is attributed to menopause symptoms and
Yes.
lack of estrogen. That's why we haven't been able to define this term or get to the bottom of it.
No, and also you could recognize that chemo brain exists and there are cognitive changes associated, particularly during and right after chemo. But I don't think there's any strong evidence that 10 years after you had Taxotere that you still have chemo brain. It's like not educating women about their bodies. And it's the same thing with telling women that breast cancer treatments and premature menopause might cause vaginal dryness. And then when you tell them, well, then the solution is some moisturizer, you're completely negating and actually not informing them of what is actually happening. If you call it vaginal dryness, you've already lost the plot, because it's the genitourinary syndrome of the menopause and it's deprivation of local vaginal hormones, including androgens. And so again, you have to name the problem if you're going to actually come up with an adequate solution. Otherwise, women walk around thinking that they're crazy and feeling guilty that lube and moisturizers don't help urinary tract infections and severely painful sex and diminished pleasure and sensation, right? And so to me, the chemo brain and the vaginal dryness are the things that really, among other things, get me fired up.
And they affect everything. The lack of sleep affects how you perform at your job. It affects how you are with your partner. It affects absolutely everything. And then that can actually create the depression and create the anxiety. So let's fast forward to today. Do you think that we're adequately warned about what menopause after breast cancer can actually look like?
No, absolutely not. The more things change, the more they stay the same. So my experience when I was first diagnosed 25 years ago, frankly, still mirrors what a lot of the patients that I see and I hear from on social media, and I meet when I'm speaking, is that they're told about the, kind of the treatment effects of chemo in terms of like how it's going to affect their breast cancer. And they talk about kind of survival and recurrence risks, et cetera. But nobody really explains what it means to be on ovarian function suppression in terms of not just, lose your ovaries or hormone blockers, not only in terms of symptoms, but in terms of the long-term collateral damages. And I think this is because neither OBGYNs or internal medicine doctors, but certainly not breast surgeons or medical oncologists or GYN surgeons, none of them have robust training in menopause. And the minute that breast cancer walks into the door and kind of the associations with estrogen, like people's eyes glaze over. They don't want to touch it with a 10-foot pole, which is really a shame because there's so many things that we can do to help women and educate them. Instead of them entering this phase with fear and trepidation, we could say to them, like, listen, I'm going to give you a hard truth. This is what's going to happen. This is what a medically induced menopause is. You can handle this. You've been through some hard stuff, but don't worry. I have so many ways to make it better for you. And along the way, if things are hard and you're not managing it, because we take premature menopause very seriously, this is the message that should be sent. Don't worry, we can adjust your treatments. We can figure out a way forward. Because when we don't do this, Melissa, women stop treatment. They refuse treatment. They give up early on treatments. They are fearful of having their ovaries removed to reduce their risk of ovarian cancer when we're talking about someone perhaps with BRCA, because they really fear the menopause. And while I think the education that's happening in the public domain, books, social media, et cetera, the news on menopause is great. It's exciting. It's really interesting, but it does leave a lot of breast cancer patients in particular, or BRCA previvors, feeling left out and afraid, because when you hear that menopause is important and that it accelerates disease risk and that hormone therapy can be super beneficial, and then at the same time you're like, but wait, what about me? It's happening to me earlier, more severe than these ladies, and they're telling me I can never have a lick of estrogen in my body again. What the heck am I supposed to do? And really, the doctors are not adequately trained to help these women. They're barely adequately trained to help the average woman. So yeah, long answer to your question, but a very, very important question. No. Patients are not being given adequate care or guidance on this. And there is no cancer center in the country that has a really robust, dedicated menopause and premature menopause and kind of survivorship program. There's a lot of holes in that care. And I think you can't be a center of excellence or advertise that you're a world famous cancer center and not have these services. It's ridiculous.
It is totally ridiculous. And I'm so glad you raised the point about breast cancer survivors and thrivers feeling kind of like, where do I fit into this menopause conversation? I feel left out. Like, what about me? And how does it affect me? A couple of questions here. Like, when you're in the office with your doctor and you feel like you're getting a stop sign, like I've had before when I've asked about estrogen replacement, hormone replacement therapy, and you're sensing that you're getting a, no, we can't do this, or not really feeling confident. what is the next step? Is it a second opinion? Is it the Menopause Society? Like, where do we go for the information?
So, I mean, I think, listen, we always want to this has to be a team approach, right? So we want to include our medical oncologist or our surgeons along with our primary care doctors and GYNs. And as a patient, listen, I'm going to just say frankly, like this has to be on you because this is the world we live in currently, and we hope to make it better in the future. But you really do have to take control. So the first step is to really be very, very clear about what your concerns are and what your symptoms are, and do a little bit of kind of education for yourself on, okay, here are the systemic symptoms, like the symptoms of like hot flashes and night sweats, and you're concerned about osteoporosis, et cetera. And then also separate out a little bit because we can sometimes manage these things a little bit easier, the genitourinary and sexual symptoms of menopause, right? And I bring this up because you need to be knowledgeable when you're talking with your doctor about these. What are the things I can do with local low dose hormones that are not systemically absorbed and that we have very, very good guidelines for? So I'm referring to the treatment of the genitourinary syndrome of menopause with local vaginal estrogen and other local vaginal hormones, right? So I think of like, that's one bucket, right? And then, okay, then there's the bucket of like, there's all these other menopause symptoms that there's a whole long list, right? And to know like, okay, what are the ones that are most impacting my quality of life? And then, I think you have to start there because what I see is patients are afraid to bring this issue up with their medical oncologist because one, they don't want to seem to be a problem patient. They want to be grateful. They want to do the right thing and stay on their treatments, et cetera. And they also think that their doctor doesn't know and might be annoyed or shut down the conversation. But you can't expect help if you don't actually tell the doctor how bad it is, right? A lot of patients are like, well, yeah, I have hot flashes, but it's okay. It's only once or twice a night. But when you dig into that, for instance, you realize like she's being woken up 2 times every night, probably for a half an hour. It takes her another hour to fall back asleep. And so there's all these snowball effects. So once or twice a night is actually a big freaking deal. For instance, that's just an example, right? So you got to be clear on what your problems are. And then how do you get help? So you're right. You may meet with the medical oncologist and their eyes may glaze over and they just be like, okay, and they shut it down. And you can tell they're not up to date on this and they're not really interested or they don't have the resources. So your next question is, I get it that this may not be your domain and I respect that, but this is really impacting my ability to have a normal quality of life. And I'm worried about the future health that I'm dealing with, right? So do you have a referral to somebody in your network that is actually a menopause specialist who's comfortable seeing breast cancer patients? Because the worst thing is to wait on a list to see a menopause doctor who's like, oh, no, I don't deal with these breast cancer patients, or I don't know how to help you, right? So you really have to be specific about what you're asking for. A good place to start, the menopause, so menopause.org, as well as ishwish.org, which is the International Society for the Study of Women's Sexual Health. They're 2 medical societies that do have listings of clinicians that tend to have knowledge on this. So that's a great first place kind of to start. And you have to be persistent. And unfortunately, it may take you a number of providers or doctors until you get help.
I wish it wasn't so complicated, but this is where we are right now. But at least we are having these conversations,
Yes.
and I'm so grateful for you. I think the golden nugget here is if you get shut down, if you feel like your clinician is getting a glazed over look, that you don't feel like that they can really support you with your menopause symptoms, then you need to ask for a menopause specialist that really understands the breast cancer patient.
And the other tip I have is, I think if you're a breast cancer patient and you're contemplating having your ovaries removed for whatever reason, because there's triple negative patients who are having their ovaries removed to lower their risk of ovarian cancer, but it's not being done to lower their hormones. All right. And so you really need preoperative counseling of like, hey, what does this mean? And can I use hormones afterwards? And that's a separate thing we can talk about. If you're contemplating ovaries removed, you must demand a plan preoperatively. I don't care whether that plan involves hormones or not, but you better have some kind of plan and you have to push, right? If you have an estrogen sensitive breast cancer and you're, using, obviously you're using endocrine therapy, it's very, very important for you to know that within the world of endocrine therapy, there are many options and kind of variations on how we can deliver that endocrine therapy. And the differences between like say tamoxifen alone, tamoxifen in ovarian function suppression, aromatase inhibitors in ovarian function suppression. There are differences in recurrence risks, or recurrence risk reduction, I should say. But for some people, particularly those with lower risk disease, there's barely a difference. And some of them don't even have a difference in overall survival. So I think it's just important that the other thing is sometimes some of the solution is to individualize the treatment that you're on. And don't be afraid to say like, wait, I may need to switch between these things, right? So pre-op counseling, if you have surgery, individualizing endocrine therapy if you're estrogen receptor positive, demanding access to local vaginal hormones, right? And we can give the listeners resources. I've got a guide, you can find on my profile or on the website. It's like a free guide of like how to talk to your doctor about vaginal estrogen, and here are all the studies showing that it's safe and effective for all breast cancer patients.
Amazing.
So those things, just those things alone can be very, very empowering. And then also remember, if you're listening to this, that there are non-hormonal ways, new non-hormonal ways to help with hot flashes and night sweats. And you're not doomed if you can't or choose not to ever use systemic hormones, because most breast cancer patients are not going to be offered them. I do think that the conversation's changing. And I think in the fairly near future, it's going to be more accessible, and you're going to have more and more oncologists who are open to, in the right patient at the right time, considering various options for hormones, okay, beyond just local vaginal hormones. So I'm talking about systemic estrogen and or progesterone, as well as we can talk separately about testosterone for low libido and sexual dysfunction, right? So that conversation is moving. And I'll just point out that not only in the Menopause Society, but also the American College of OBGYN, as well as in the medical oncology literature itself, just in the past year alone, we have had multiple publications saying we can't hide from this conversation anymore. Here are some ways we can look at it, even though we don't have perfect data. So I think that is really helping kind of push things in a more progressive forward way.
I'd like to give a very special thanks to Novartis and Daiichi Sankyo for supporting the Cancer Fashionista Foundation and making this episode of the Signature Series possible. Even though we aren't exactly where we'd like to be right now, we're definitely going in the right direction.
100%.
And just having these conversations and having someone like you to educate us as the process is evolving for the patient, even though we don't love that the onus is on us, it is on us in a big way right now. So at least we know what questions to ask. And, one thing that I still actually need to learn about in all of this that can be very confusing is what makes menopause after breast cancer different from natural menopause? Like, what are the main differences and why do they need to be treated so differently?
It's not, because menopause due to breast cancer treatment is not natural. In fact, it should really have its own actually, label. We've got to come up with a name to make it separate. And so the most important thing is you are not your mom's menopause, okay? Unless your mom had breast cancer, right? So, natural menopause happens at the average age of 51. Natural menopause is a slow progression and transition. They have the perimenopause, like a slower lead up. And for the vast majority of women in natural menopause, hormone replacement therapy or menopausal hormone therapy is the benefits far outweigh the risks. It's standard of care. And it really, we've got multiple FDA approved options, right? And natural menopause, while it is a time of disease risk acceleration, meaning higher risks as you go through menopause for heart disease and bone loss, etc. You can't compare that level of risk and those symptoms to what happens when it's abrupt, surgical, or premature. So understanding premature means under 40, early means under 45. And putting aside breast cancer, the intersection with breast cancer for a moment, we have clear practice guidelines that if women have premature menopause or early menopause, but particularly menopause prior to 40, that they have just outrageous high risks of all of these chronic disease issues, as well as greater sexual dysfunction, more mental health issues. All of the symptoms are much more severe. And we really, the standard of care is full hormone replacement therapy up to at least the age of natural menopause. So that's how we think about the general population who is experiencing that early premature menopause for whatever reason. So this is why when it's due to cancer treatments, it is really unique. It is because your risks are more, your symptoms are more severe, and often you don't have all of the same solutions that someone who's much older in natural menopause has. And so we have to take it as seriously as we do your breast cancer treatment itself. And if we don't, we are failing women's cancer care, full stop.
I
And
couldn't agree more.
yeah, and it's so, it's kind of like, we wouldn't accept this kind of suffering when it came to any other medical thing. Like, we wouldn't cut off your leg and say, well, it's just your new normal. See how it goes, right? Like,
No way.
having osteoporosis and breaking your hip is a problem when you're 80 or 90 years old. We don't want that to happen. But being at risk for severe bone loss and osteoporosis when you're only in your early 30s or sometimes in your 20s, and how are you're going to survive your breast cancer and then have, these fragile bones down the road? Like, there's lots of things to do. Don't be scared if you hear this. Like, we can do a lot to prevent that, but we can't do it if we don't, speak to it up front. And you can kind of make that analogy to kind of every one of the menopausal concerns and symptoms. So I just think, and I've had patients say, well, when I asked my doctor, I was like a little worried about going through, starting my ovarian function suppression on my ovaries. And the doctor says, well, don't worry. Like, I went through menopause and it wasn't so bad for me. Or
Not the same.
Or my mother-in-law, just had a hysterectomy and, she's actually doing great. I'm like, excuse me. Your mother-in-law was probably not 34. And, when you went through menopause, doctor, you went through it naturally. Like, it may not have been bad for you, or actually maybe you gaslight yourself because you're of a generation of women. Let's face it, some older physicians who went through menopause themselves, particularly those who were not menopause specialists or OBGYNs who knew about hormone therapy because of all the fears with the WHI, there is a generation of physicians who are like, yeah, suck it up, girl. I went there. I did it. I had that happen to me too.
Like getting your period.
Yeah,
You'll get through it.
it's
You get
natural.
some cramps. Yeah, take an Advil.
It's a part of life. And I go, well, that might be true in some semblance if you're talking about someone entering it naturally. But how dare you compare your natural menopause at 53 to mine at 28 or 34 or 43? It's just not the same.
It is not the same. And I remember when I was 39 and I had my ovaries removed prophylactically, I was told, oh yeah, you might have some night sweats, but like there's so many women that are just fine. It was so minimized. I cannot even explain. And now fast forward like 13 years later, I'm just now realizing that the anxiety and the depression and my chemo brain were, lack of sleep and all of those things could be treated with hormone replacement therapy, but we're just now all getting caught up with the data.
Yeah, and particularly in your case, which I know you've talked about, that you're a triple negative survivor. And so your ovaries coming out had nothing to do with treating your breast cancer. It had nothing to do with lowering your risk of, getting a recurrence of your breast cancer. It had entirely everything to do with preventing ovarian cancer. And if they were happy for you to have your own natural hormone production for all of those years after your breast cancer diagnosis, why in the hell could they not be considerate of you having some form of hormones after you removed those ovaries? Because what people have to understand is it's an immediate, very abrupt lowering of not just your estrogen, your estradiol levels, but also, your ovaries create about 50% of your testosterone production. And so women who lose their ovaries prematurely, have a much higher rate of sexual dysfunction, low libido, and also actually just published this month in the Menopause Journal, which I'm writing a Substack today on it,
Can't wait to read it.
that the genitourinary syndrome of menopause after surgical menopause is a unique phenotype that presents as more severe. So because it's not just the genitourinary syndrome of the normal menopause, it's the genitourinary syndrome of surgical premature menopause. And why is that different? Because even a postmenopausal ovary produces androgens. It produces
Mm.
testosterone. What we don't tell patients is that your vulva and your bladder and your urethra and your vagina, and especially the vaginal vestibule, the opening into the vagina, that tissue there is exquisitely sensitive to the loss of testosterone. So, that's just another great example of how we're not informing patients of this and that the symptoms are more severe and different.
I'm so glad that you brought up all these different, the examples of the different hormones. And I want to kind of dial into this for a second because I know
Sure.
when we go on social media, we see so
Mhm.
many amazing experts like yourself talking about estrogen, vaginal estrogen, testosterone, progesterone, hormone therapy. Why is there so much confusion and how can we kind of like simplify these terms that are flying around?
Well, I mean, it's confusion because, most women are not really educated about what's happening to their bodies, and doctors aren't proactively talking to patients about what to expect when they're, say, experiencing surgical menopause. So, kind of for your listeners, just keep in mind that your ovaries produce estrogen and testosterone. And then every time you ovulate, that second half of your menstrual cycle, you're producing progesterone. If you are menopausal for whatever reason and you're choosing to use hormone therapy, systemically, we typically now call it menopausal hormone therapy, really to send the message that the point of menopausal hormone therapy is not to give you back super high levels and mimic what you were when you were 30 or 35 or younger, but to give you back enough to treat your symptoms like hot flashes and night sweats and protect from bone loss and then lots of other benefits, right? Um, but the term menopausal hormone therapy has kind of changed from HRT, hormone replacement therapy, which was what a lot of people still call it, right? But HRT kind of sends the message that we're replacing high levels. So when we think about MHT or HRT, we're thinking about estrogen. And if you have a uterus, you have to have progesterone because if you give estrogen without a progesterone, your uterine lining can thicken up. You could have bleeding and it can even put you at risk for uterine cancer. So if we give you the right progesterone, then that's all good, right? If you don't have a uterus, we can use estrogen alone. If you don't have a uterus, progesterone can be optional, but it's not required. So when people talk about HRT or MHT, they're really talking about those two hormones systemically. Testosterone, we don't typically include in that mix. We think of testosterone, although some might argue it should be in that mix, but that's a separate conversation. But testosterone, we have really good evidence for its treatment using low doses for women's hypoactive sexual desire disorder or low libido. And it also improves other sexual function, like it seems to improve arousal and an orgasm. And also we know has a beneficial effects really on the genitourinary symptoms. So that's how you kind of think about those hormones in terms of systemic, and then always understand that we also talk about hormones in a local application, so not systemic. And that's when we're talking about it's used for the GSM, where we're applying local either vaginal estradiol or vaginal DHEA, which actually converts to estradiol and testosterone and works on both of those receptors. So it's important for you to know that there's a difference between local and systemic, and that each one of those hormones has impacts on the local tissue, the rest of your body, and also your brain. And I think that's the other important point, kind of circling back for your initial question about chemo brain, is that it kind of reminds us that when you lose estrogen, progesterone, testosterone, you're losing its impact on your brain. These hormones have profound impacts on your brain function and mood and etc. And so I think this is important so women can understand, like, oh, I'm having these new changes with how I'm thinking or how I'm feeling in my mood and depression. Yes, it's because of your breast cancer diagnosis is pretty hard and can cause a lot of mental health issues, but it's also just the direct loss of the hormones that are causing that, right? So I think it's just important to keep on explaining to women that these hormones function not just in your breasts, they function all over your body, right? And we all have estrogen receptors everywhere in our bodies, right? And testosterone receptors and progesterone.
Thank you for breaking this down so beautifully. And it's like in my mind, I'm thinking there's like two, just to really simplify it, there's like two buckets. There's the mental health component of those symptoms of anxiety, depression, and the sleep issues. And then there's the sexual dysfunction. So I think to kind of bring it all home, just to make sure that you express to your doctor what your issues are. And we're all so different. We all have different breast cancer, different stages,
Yes.
different treatment, and we're all going to have a different answer
Yes.
or a perfect anecdote or recipe, if you will, for
Yes.
HRT.
Yes, yes. And so hormones, you can think about, so if the doctor's eyes glaze over hormones, kind of just understand that, like, doctor, I want to talk about, like, also, like, there's a difference between, using local hormones and using systemic hormones. And then there's a difference between those hormones. And now we do have, again, I never want to leave out that we do have a lot of non-hormonal ways. There's two new medications. We should mention fezolinetant and elezonitant. So one is called, brand name is Veoza. The other was Lincunit. These work specifically on very similar receptors in the brain where estrogen is working to help with hot flashes and night sweats, and then resulting insomnia. So that's just an example of how science has moved forward there. And so I would really encourage patients to know that that is an option, but please don't let anybody say that your new onset of panic attacks or insomnia or whatever are just chalked up to being stressed or you're sad about breast cancer. Understand it is a brain reaction to the loss of hormones.
Right. And these are chemicals that are
just
that
be
are
honest
gone.
with women. Again, you're not doomed, but you really have to, it's got to be all hands on deck, and you don't have to feel bad. I have met many patients who were really feeling very, very broken by their breast cancer treatments from a hormonal place. And not everybody I see, they're not putting everybody in hormones, certainly not. Very few patients really are using systemic hormones, but there's a lot of ways we can help you. But again, we can't help you if we just send you away with an antidepressant and some hyaluronic acid. It's just not enough.
Right. And I think it's on both sides. I think it's for the patient to not feel that shame
No.
that just because, yes, you're surviving breast cancer, you're thriving breast cancer, that you shouldn't, explain if you're having major issues, and it could be chalked up to, lack of hormones. And I think, for the patient to have the courage to speak up and share those concerns, and then have the right match. This is the perfect scenario, right? The right match where the clinician completely understands and know how to support it. So I think it's, it's both sides. And that's exactly why I wanted to have this conversation, to educate the patient community and to tell everyone you're not going crazy if you are having, issues with memory or, major sleep issues or anxiety, depression, sexual dysfunction. There are ways to treat it. And like you said, it doesn't always have to be hormonal. What would you say, like, are the top 3 symptoms that we should never assume that we should have to live with? And I think I know part of the answer.
Well, the first one is any of the genitourinary syndrome of menopause symptoms, because we can use not only lubricants and moisturizers, but really the gold standard, because those are just Band-Aids, frankly, is local safe vaginal hormones. You can get your pelvic health, sex life, painful sex, bladder health. It can all come back, even if you've suffered for a really long time. I've seen it happen. So never deal with that. There is no reason that you need to be not sleeping and suffering from hot flashes and night sweats. We have so many ways we can treat it. We are so grateful to have these new non-hormonal medications. And for some women, we can consider hormones. And then the other thing is the fear of, you should not settle that because you've had an early premature menopause, that, it means you're destined to have osteoporosis, dementia, or cardiovascular disease. But we have to be honest and give some tough love to our younger survivors in particular, that yes, it sucks. It's totally unfair. And I'm so sorry this has happened to you. I get it happened to me. You do have to also take responsibility, because you can, the biggest way to prevent heart disease is to exercise, to cut out alcohol, to eat healthy. You don't have to be on a crash diet or some crazy extreme exercise. It's those everyday choices that go a really long way. And we now have ways to help you if you've gotten into a place where you've gained a lot of weight, or you feel you're really, not in a good place in terms of your physical activity, your body composition. And that's where I'll mention that I think GLP-1 medications and its use in breast cancer is really important, because These women say to me, you know what, Dr. Men, I try to exercise and I'm trying to eat well, but you know what? I can't, I'm exhausted the next day, which we know it leads to poor food choices, lack of motivation. Your joints are terrible. And so you can't go to the gym. We get it. And, maybe you've put on some weight and that adds to all the other symptoms and, fatigue. It's like a snowball effect. So I am finding the appropriate use of lifestyle with sometimes a GLP-1, which can help women, even if you've lost 5 or 10 pounds, those things can help. And then, of course, lifestyle medicine and exercise, all of those things, targeted things for your hot flashes and night sweats, give some target to the GSM. All of a sudden, we have a bunch of different solutions hitting at different angles, maybe adjusting your adjuvant endocrine therapy. And then maybe for people like you, who maybe could consider systemic hormone therapy, we put it all together. And suddenly, what seemed impossible and seemed like I am so broken, suddenly, and it may not happen overnight, but over the next few months to the year, you could be back to a more healthy, vibrant, happier person. You just need like all the tools. And there is a little bit of like there is some responsibility. Like you've got more than the average person. You've got more reason to do the good things than the average person. Because not only is it going to help with your menopausal symptoms and protect your long-term health, it may actually lower your risk of breast cancer recurrence or getting
Sure,
a new breast
lifestyle is,
cancer.
I mean, there's so much data to prove, that making the right lifestyle choices and eating
Huge.
well, hydration, I'm terrible drinking water and and the sleep, those things all, they do add up. They do contribute to the whole
They
picture.
so much. And so I know this is so many things, but what I tell patients is like, it really comes down to common sense. Do the common sense things and habits beget habits. And then add in the directed medical things, treatment things that we discussed. And you slowly, and you don't have to do it all at once, right? But you're worth it. The thing is, breast cancer patients have not been told that this aspect of their lives are worth care because there is no medical center out there showing like, hey, we really care about this. We're elevating. This is important. What they're only elevating is this is really important. You should just stay on estrogen deprivation a little bit longer. Like it's all about squeaking out a few extra percentage points in recurrences, which is so important. And I'm glad that's there. But
Totally.
this other part has to also be there, right?
It absolutely does. It absolutely does.
Yes.
What is the one thing that you wish that every breast cancer survivor knew about menopause, but they probably haven't been told? If there's one big takeaway here.
Um, that loss of ovarian function is way more than just losing your reproductive capacity, and your health needs to be valued beyond just your baby making capacity when it comes to your ovaries. And the reason why I kind of want to end and say that is because we've got robust literature, guidelines, and studies to show that women can actually pause their very important endocrine therapy for up to 2 years to get pregnant, to have a baby, right? Triple negative patients, after they get through that maybe first typical 3 to 4 years where the recurrence risk is highest, pregnancy is encouraged, allowed, right? So I use that as a little bit of a mental exercise. If they're allowing either a pause in endocrine therapy or for whatever type of breast cancer patient to consider having a pregnancy, which is filled with hormones, right? And maybe doing IVF filled with hormones, etc. Why can't we have the conversation about how we're dealing with the suffering of premature menopause and surgical menopause? Why is one valued and the other one is completely minimized? It's not okay.
And that is the issue. And that is it right there. It's
It
it's
is.
so true. And you actually we're gonna wrap up soon, but I have actually this is almost more of a
Mhm.
selfish question. I not long ago had a doctor say to me that, you know what, Melissa, you're 13 years out. The hormone replacement therapy really probably won't do much at this point. Is that false? Is it ever too late?
No. So here's the thing. First of all, you're still quite young. So I think the problem here is that, there's something called the window of opportunity. And what we know is that when women initiate hormone therapy within the first 10 years of entering menopause, that's when We have data that shows it can lower cardiovascular disease risk and this is less clear, may lower risk of dementia. Okay. And so we would prefer women who are, eligible to start within that first. And then also the longer you're without estrogen and the older you are. Now, this is particularly true for someone who is, say, natural age of menopause was 50 and now maybe they're 63, right? So that 63-year-old has gotten older and may have other chronic disease risks. They've probably gotten atherosclerosis. I mean, they're getting older, right? So they have other medical comorbidities that might put them at a slightly higher risks to initiate estrogen at that point. Although what we know is that's highly dependent on if those medical conditions are controlled and if they're using lower doses of transdermal estradiol, which does not provoke blood clots and cardiac risks, right? So that's one question. But that question doesn't necessarily apply to someone who went through menopause at, say, 35 and now maybe they're only 48, say, right? Like they're still, or they're in their 40s, right? Or maybe early 50s, and they're otherwise healthy. Now, what I say to them that, well, I mean, the same thing's going to apply. Like whatever cardiac risk protection is probably either not going to be present or not going to be as robust as it would if you started it earlier. But ask those women about their quality of life. They will tell you their menopause symptoms are still bothering them a lot. And maybe their hot flashes aren't as bad as they used to be. But the average, they last for an average of 7.5 years. And for at least 10 or 15% of patients, it will last beyond 10 years. So they may still be having symptoms. And everything about menopause is not just hot flashes and night sweats. It's a whole host of things. And osteoporosis protection doesn't just suddenly disappear if you start your hormones late. What we know is even 10 years and beyond, like you can initiate estrogen at any time and it will prevent further bone loss and can actually help contribute to your efforts to build backbone and prevent osteoporosis. So there's lots of reasons why we start hormone therapy in that beyond 10-year window. But traditionally it was like, start early, 5 years only, end early. But that's very old school thinking. And actually the new guidelines actually have taken that language out. And so I think it's very dangerous to apply how we deal with, say, someone who's 70, who's coming to us being like, hey, I missed the boat. And
Right.
versus someone who was like, Dr. Menn, I went through menopause at 28 and now I'm 41. And they say, I've missed the 10-year window. I'm like, okay, no, again, we can't compare natural menopause with this early premature. We have to look at
They
you
are so different. And I even
as
realized
an
how different until we
individual.
spoke today. They're so, and individual. Absolutely.
Individual. And so what we do is like, what would be your benefit for starting now? Okay. So we figure out what are those benefits? What are the risks, right? And we can make that educated, kind of decision and weigh that and decide, okay, if we're going to use hormone therapy after this 10-year window, what's the best way to use it? What's the best dose? What's the best formulation? What are we going to avoid, et cetera? And how are we going to follow you? Those things are actually not that hard.
They're not. And
No.
thank you again for breaking this down so beautifully. And I love that, we're able to look at this hormone replacement therapy, not just for taking care of the symptoms, but for actually, providing, stronger bones and actually helping us with longevity and other things that are actually really positive. It's just so important for us to know exactly what we're looking at in terms of how are we going to improve our quality of life now and how it could even help with preventing certain things going forward. I could talk to you all day about this, but I know you have patients and you have things to do. But there's a lot to unpack, and I think we covered a lot. I know when we were first talking, you were like, Melissa, this is a lot, but we really,
we get it in.
We get it in. We get it in. I cannot thank you enough for sharing both your expertise and also your personal experience and your story with all of us today. Where can we find you online and learn more about you and your work?
Yeah, so I'm most active on Instagram, so that's just Dr. Menn, OBGYN, and also on Substack with the same name. And my website is just drmenn.com, and I do telehealth and see patients in many states and also do educational consults in states where I'm not actively licensed in. And on my Substack in particular, I have a lot of, of these resources that we talked about and guides for you to get started. My favorite one is like Menopause and Cancer Start Here. It's not behind a paywall. And you can get a lot of tips and advice. And I'm doing an ongoing series with our friend, Dr. Eleonora Teplinsky,
I
which is,
saw that. I'm like, this
yeah,
is like the power duo here.
yeah, she's a medical breast oncologist and she's wonderful. And we've got a great friendship and rapport going on. And we are doing the OBGYN meets the medical oncologist and kind of just going to be meeting every, once or twice a month to talk about the issues of this area of shared clinical responsibility that we have for our patients. So yeah, so I think that's another fun source for your listeners if they want to learn more from both an oncology and a menopause specialist perspective.
Fantastic.
Yeah.
That's amazing. And I love that you are wrapping up the world of menopause and breast cancer into one very understandable place for us. And you're,
Yeah.
I hate that you had to go through this yourself, but you know
Yeah.
so much having walked the walk. And I just want to thank you again, Dr. Menn, for joining us here on Dear Cancer, I'm Beautiful. And to everyone listening, I hope today's conversation reminds you that your quality of life matters, your symptoms deserve attention, and you don't have to navigate menopause after a breast cancer diagnosis alone.